Okay, so again, I'm saying good evening. I hope you are doing well. Okay. Uh, okay, so we have 55, 56 participants with us. Good to go. Okay, more are joining. Just a minute, guys. Just a minute. We can wait for 1 more minute so that maximum people can join us. Okay, let me brief you till then. Okay, I will be briefing you today first what is coming in our whole session today, right? And then I will be sharing slides with you so that you can understand it in a very efficient way, right? So please understand, open your ears as much as possible, right? So understand the concept clarity because the title may be new to you, right? Maybe you are aware of, I don't know, so I need to explain you that what is coming in the session today. Okay. So first I will orally explain to you and then we will move to the PPT because my PPT doesn't have so much of theory, right? So much of theoretical things I didn't include and I never includes, right? So my purpose behind PPT is to only reflect the topic and the subtopics to you. And my learning objective and my aim behind putting this short content on the PPT is, see, this is the exact way to learn, right? This is the exact way to teach also. So I believe that minimum content should be there in the PPT and maximum you should understand by the concept clarity. Okay. I and someone else will never going to ask you what is inside the theory or explain theory to me. Okay. Or explain the definition, explain the, whole principles. No one is going to ask you. Everything is available on a one click, guys. Okay, in an interview also, in an competitive exams also, you will find always at the base there is always a concept. Okay, and your concept should be clear, then and then you can attempt those tricky MCQs or you can attempt those tricky questions in the interviews as well. So my purpose is very clear that by looking at certain sentences, by looking at certain topics, you should be clear that what is, the definition or what is the concept of that thing. I need to dug your mind. I don't want to mug up all the theory, right? Always. So please remember and please understand that what is coming today. So before we get started, I want you to think about one very simple question and I'm expecting little answers from you. So if you have any, you can just simply put into the chat box, right? So let me ask that why doesn't the same drug does the same work in the same way in the every patient we give? Okay, so that question should be there in your mind if you are a healthcare professional. Like if there are 10 people suffering from fever and everyone having a paracetamol, simple example we are taking, right? Paracetamol 500 mg or just imagine Dolo 650, right? So, क्या होता है? Like what is the effect? Everyone will be having a same effect, like same duration में सबको fever खत्म हो जाएगा? No, right? Because there should be some of the very basic principles, some of the very basic theories involved, right? Because everyone is different, the way their metabolism exactly. Also, if you know, do you know about gene interaction? There is also a genetics which is involved, right? Yes, genetics, age, and many factors are there. Many physiological factors are there. And gene interaction is the new term for us. That is a pharmacogenomics, right? So, a very big term, pharmacogenomics, which is involved. And gene, yes, everyone is writing in the chat box. I'm happy to see. And gene is interacted with the metabolism of the drug process, and that is the making the again the whole mechanism will be different, and that is completely depend that how much amount of drug is being absorbed. Okay, whether the patient is rapid metabolizer, whether the patient is slow metabolizer, normal, ultra rapid, right? Everything depends on that thing. So nowadays we have current name. We have current in our current pharmacy. Actually, we have a very big terms coming, that is a precision medicine, right? Someone is writing also in the chat box. Yes, so we have to know about precision medicine, personalized medicine, which talks about what is the exact category of the people. And can you please unmute yourself? Sorry, can you please mute yourself? Just a minute. Okay, fine. So I will give you the access if you want to speak. Do not worry at the end, but it is quite disturbing in between. So I'm, not giving you the access, but at the end of the session, you can ask as many as question possible. Okay. So yes, we were talking about many factors are involved, right? And that's one question is exactly why we are here today, guys. So in a clinical practice, what happens? We rarely meet the perfect textbook patient, okay, which talks about individualized medicine or, precision medicine. So instead, we met, so variety of peoples with multiple diseases all the time, like people who are having some of the complex physiology, right? And a long medication list, that is polypharmacy, right? Polypharmacy is also the biggest challenge in India right now. And somehow we are expected that to decide the perfect dose for each of the patient. Okay, and that is what the decision making is all about. So, in today's session, we are going to dive deep into this real world of advanced pharmacotherapy. So, I hope you are aware of the title and you are aware of what is coming inside the session. So, I hope that you just before proceeding with the session, you just go and check the brochure that what is the module today and what is the title of the module, and subtopics are also written in the brochure, right? So, yes, it is difficult to do genetic testing on a daily basis. You cannot go, and that is what I'm suggesting, and that is what I'm talking to you right now, that every day you cannot go with the genetic testing. Genetic testing is costing also very high. Okay, and no person is directly agreeing also to go on a genetic testing, guys. To convince patient for genetic test is also difficult task in country like us. Okay, so there are lots of challenges. Yes, what is solution? We are going to discuss today. Okay, so based on the condition, guys, based on the condition, based on your whole, the case, you can decide further what to do next. And this requires skill. This does not require any therapeutic, no. If you have a good therapeutic knowledge, good and strong base of your pharmacology, yes, you can decide based on that. But that requires some of the critical, decision making skill, and that is exactly why our course is. Right, so we will discuss that how disease change, drug responses, how this pharmacokinetic and dynamic models help us to make smarter decisions, and how we optimize doses, in challenging situations, and how we further prevent those unexpected adverse drug reactions that can turn everything upside down. Right. So those are the topic for the discussion today. So don't worry, this won't be heavy. It is, rule based lecture. I can say it is a rule based lecture. So this is the second module. So I'm not going very, heavy things. I'm not going on a very heavy things. We will look at some real cases, some real practical examples, and some of the things that you will actually use when you step into the clinical practice. Right. So sit back, relax, and let's decode that how to make this pharmacotherapy very, very safe, smart, and patient centered. Okay. So this is exactly what we are going to discuss today. I hope the outline is clear in your mind so that we can proceed with the PPT now. Okay, may I know the answers? I hope the some, you can say, blueprint, or some basic learning objectives are clear in your mind so that I am able to share the PPT. Okay, so from the starting, I cannot share and going through the theory. First, I need to take you the concept that why we are discussing today. Your why should be very, very strong, guys. Whatever you are learning, if your why is strong, you are good to go, right? Because that's make you more curious to learn about the topic. Okay, so that is my objective. Okay, I'm sharing the screen with all of you. Just give me a minute. Okay, I hope the screen is visible. Yes, okay, thank you so much. And here we have our, yes, we have our PPT. We are back with the title. So I want you to remind yourself that what we are learning today, right? Advanced clinical pharmacy practice and decision making is the course. And we have today the second module, which talks about some of the advanced pharmacotherapy concepts. So you will be seeing today the whole, the different perspective of thinking related to pharmacotherapy. Okay, how we are saying in the lecture that I know, because I'm also a PharmD and I was also working as an assistant professor. So I am very much aware that how what is the therapeutic concepts in the textbook and what you learn in a classroom and not, right? But this is something new because I'm bringing something new every time, so that won't bore, that is not like boring. Anything is not boring here. So you will be seeing some of the very practical side, but involve yourself in it. Okay. Okay. Let's start with the session roadmap, or you can say learning objectives of the today's session. So you will be seeing today all the pharmacodynamics in the complex diseases. I hope you know what is PKPD. Yes. Pharmacokinetics and pharmacodynamics, right? Kinetics and dynamics, what body does to a drug, what drug does to the body, right? Particularly in this session, we will saying what drug does to the body, which is a part of your pharmacodynamics. Okay, in a very complex diseases, we'll understand. For example, we'll see some of the cardiac disease, sepsis, and all, where how exactly drugs are being performed and therapeutic decisions are, making. So we'll see that. We'll also see some of the PKPD model that is important. We'll also see some of the dose optimization techniques that can be adapted by the healthcare professionals or the clinicians as well. And of course, if you are a pharmacy student, you should be aware of the dose optimization. We are here to suggest them, right? Also, we'll see how to manage ADR, and we'll see some of the real case examples. Okay, so in today's session, we will first look at why this advanced pharmacotherapy is important, especially with the patient who have very complex conditions and, very much multiple medicines they are using, like patient on polypharmacy, right? So we will see that today. Next, we will understand how this pharmacodynamics are changes in a different disease states, because the same dose can behave very differently from one patient to another. Now, you all agree with the point, right? Also, we will then explore some of the PKPD model, which help us to link the drug concentrations with the clinical effect. This PKPD model, how it is helping you? This is helping you with the drug concentrations with the clinical effect. You can link. Okay. And you can also learn how these models further, guide you some with the some of the smarter therapeutic decisions. So PKPD model is having this importance, right? After that, we will move to the individualized dose optimization. That means how we adjust doses based on organ function, based on weight, based on genetics, based on disease severity or other comorbid conditions, right? Other factors are also there. And we will also cover how to monitor and how to minimize this adverse drug reactions, because safety is as important as efficacy, guys, right? So that is the reason why we have subtopic of ADR management. And with that, we will see some of the real world case examples to make these concepts very practical and clinically relevant also. Okay, so yes, now let's start with the importance. So, as I earlier told you, that we always start our session with the importance, so that your why, it should be justified in a very better situation, right? So very first condition is a multi-morbidity, right? So this advanced pharmacotherapy is very, very crucial, because most patients today have this multiple disease condition. I hope you are aware of morbidity term. Multiple morbidity means multiple diseases, right? And they are also on, many, many medicines, which you can say the word polypharmacy. Okay, and show a lot and lot of variability, that is high variability, okay, in how they are responding to a particular treatment. Okay, so this is very crucial, because most patients today have multiple disease condition, they are using multiple medicines at once, and also show a lot of variability in how they are responding to a treatment, right? And the same drug and dose, that can work perfectly for the one patient, but it cannot in this other one. That is precision dosing needed, okay, or even cause harm also in another one. right? So also you need to remind yourself some of the very big examples we are having in our history. For example, we have example with us, I can give you, if I can remember, codeine. Okay, so Tylenol number 3 करके एक very popular drug आया करता था, which was prescribed for the postpartum pregnancy में postpartum pain के लिए दिया जाता था. But one mother was taking the medicine, and the infant which was healthy at the time of birth, he dies, because the mother was ultra rapid metabolizer. So that was the drug Tylenol number 3, which was codeine. And if you know, codeine is converted in the morphine, right, with the help of some CYP family enzymes. And patient was ultra rapid metabolizer. Okay, she is having one more chromosome extra, and that is the reason why codeine is much more likely to convert into morphine very speedily, and it is transferred into the infant, and infant dies. So that was the biggest case in our history we are having, that talks about genomics, that talks about precision. Okay, precision medicine. So that is the reason why we need precision dosing, right? And also deeper understanding is required for pharmacokinetics and dynamics to make more safe and effective clinical decisions, guys. Okay, so you have here example like two patients with the pneumonia that can have entirely different vancomycin exposure due to their BMI, due to their renal function, due to because of SIRS, right? And maybe because of comorbid conditions, right? So just imagine this kind of examples, and now this example is only for your understanding, but this is very simple example. In complex condition, you can imagine what will be the situation. Okay, let me tell you, in ICU, many deaths are happening because of the drug interaction, or because of drug induced condition, and it is not reported, right? It is not reported, but if you have a very strong knowledge, and if you have a very strong concepts clear in your mind, you can identify the loops in the ICU settings also, right? And trust me, they are not dying because of the disease, or because of some other things, but they are dying because of the drug exposure. And we as a healthcare professional are here to save people, right? Not to kill one. Okay, so that is the important of learning this and making us more smarter in decision making, right? So that is the importance of the topic today. Let's move to the next slide. So we have four sections today, and section one talks about pharmacodynamics in the complex diseases. Okay, so I want you to recap. I want you to, if you are already aware of the term pharmacodynamics, that's well and good. If you are not, just understand what it is. So that is a recap, I think, a slide I can consider. So when you are aware of the term, okay, you can remember again, once again. And those who are new for, this term is new to you, you can understand it. Okay, so what do you mean by the pharmacodynamics? So, pharmacodynamics is basically what the drug does to the body. You can remember by the D here, pharmacodynamics. Okay, it is D. So, you can remember drug does to the body. While in PK, there is what body does to the drug. Okay, so PK talks about always ADME, while pharmacodynamics talks about what drug does to the body. Okay, so it explains that how a drug's concentration leads to a therapeutic effect. Okay, it is explaining it to you the whole concept of how the drug concentration is leading further the therapeutic exactly expected effect. Okay, through whatever, through receptor binding, through potency, through efficacy, right? Anything. And it is also remind us that every drug has a therapeutic window, guys, right? What do you mean by therapeutic window? Therapeutic window means a therapeutic index. Okay, meaning any drug can have a minimum effective concentration and maximum safe concentration. Minimum concentration which is required for therapeutic effect, and maximum safe concentration beyond which you cannot go, otherwise toxicity will be there. Okay, the range between these two known as a therapeutic window. So I can give you example. Pantoprazole is known to you. Pantoprazole, right? Pandi tablet is very popular. 40 mg twice a day prescribe किया जाता है. तो per day उसका dose होता है 80 mg, right? So we can say that minimum 80 mg per day is required. But that is nothing like if you are having a more acidity problem, you can go for two tablets in the morning, two tablets at the night. No, right? So you cannot go beyond the particular dose. You need a 40 mg at once and 80 mg per day. right? So that is a therapeutic window, therapeutic range of using pantoprazole, right? So this is the simplest example I can give you, but we have, many more examples with us that can be give you the better idea about therapeutic window, right? And also toxicity window, meaning a maximum safe concentration ke upar wala dose, right? So yes, this is very important. It also, this pharmacodynamics reminds us that every drug has this therapeutic window where it works well, and a toxic window where it can cause the harm. So understanding these concepts will help us to choose the right drug and the right dose for the each of the patient. Okay. So your pharmacodynamic profile should be very, very, very strong in order to, make the correct decision. Okay. So when I say decision making, dynamic jo hai, pharmacodynamic play a huge, huge role. Okay. You should be aware of. Okay. Next, we have how complex diseases, alter further the pharmacodynamic profile of the particular drug. Okay. So if the person is suffering from any kind of complex disease, okay. So in complex disease, the body doesn't respond to a drug in the, usual way, in the way it should be. Okay. So please remember, if the person is suffering from complex conditions, your responses of drug changes. Okay, you cannot go with the traditional treatment whatever you are assuming it is right. Okay, so receptors, complex disease में क्या होता है, receptors may increase or decrease. Okay, signaling pathway may change. Okay, inflammation can also alter the drug responses. Okay, you can see here, inflammation can also, I can say, alter the drug response, and comorbidities like diabetes or heart failure further also modify the drug effect, right? Comorbidities, you can see here, the diabetes, CKD, obesity, heart failure is written here. So that can also make changes in the how the drug will behave. So this overall means that even the standard doses can produce, weaker effects and stronger effects further, or unexpected reactions, making personalized pharmacotherapy very, very essential when you are going to deal with some of the complex disease. But first, you need to understand what are the complex diseases. Okay, so I have 10 slides for you to understand after this slide how the complex disease alter pharmacodynamics. Okay, so that it will give you a clear idea when you are dealing with those patients who are suffering from complex conditions, you can make a better and effective decisions. But when it is possible, once you experience that yes, these are the changes that can be possible, so I'm introducing those changes. Okay, and complex diseases, how it is altering a pharmacodynamic of the drug, which is not discussed in the classroom, guys, right? Because we only in the classroom, which is in a restricted time also, your professors also wants to tell you about many things, but they are unable because they also need, to complete the syllabus in time, timely, and they have also a very restricted time, right, to deliver. So basically, this is something which is very important, and I personally think that this practical thing should be included, right, so that one can make a actual clinical decision. Okay, so let's start with the comp. I hope you are clear with this slide because this is very important. So please understand that some of the receptors can change, right? Some of the signaling pathways may altered. Inflammation also mediates some of the changes, and comorbid conditions also has effects on how your drug will perform. Okay, let's now talk about genetics today, because if I will talk about genetics, okay, I had in previously in March and April, I had a big course on pharmacogenomics and personalized medicine. Really good course, 3 months of course it was, and it was amazing. Okay, more than 100 participants we were having. And in that course, I talked about it a little bit, extensively. So you can just assume that how much amount of time is required if I say a single name, that is pharmacogenomics. Okay, so let's not talk about genetic part right now, but apart from genetic also we have multiple things. First, we need to understand when it comes to complex diseases and when it comes to drug is not behaving as it should be. Okay, so let's start. Okay, first and foremost thing I have, that is the pharmacodynamics in the sepsis. Okay, so what happens in sepsis, guys? You should be, able to understand that sepsis is a very important condition. Okay, sepsis is very important condition. When you have examples in ICU ward also, you will be having a lots and lots of cases of sepsis. So let me remind that sepsis is a life threatening, I can consider, right? It is a life threatening organ dysfunction, you can say, okay, which is caused by body's extreme and dysregulated response to an infection. So it is body's own response, extreme response and dysregulated response to an infection. That is the reason why sepsis is happening. And instead of fighting the infection normally, the immune system, our own immune system, goes into overdrive, okay, overdrive, and start damaging the body's own tissues and organs. That is what the meaning of sepsis is, right? Commonest causes we have, that is the bacterial infections, okay, any kind of lung infection like pneumonia can also turn into sepsis. UTI we have, abdominal infection we have, skin infections we have, right? And fever is the main symptom, okay, fever, fast heart rate, and low urine output also is the you can consider a symptom. Also chills and extreme weakness is happening in the sepsis, right? And there is a difference between sepsis and septic shock, okay, but I will not discussing it right now, but let me just brief you about so that it will be clear to you. Sepsis means organ dysfunction, you know and septic shock means severe subtype, we can say, okay, it is a severe subtype. Persistently low blood pressure you will observe in a septic shock, okay, and very high mortality risk, death risk is very high with the septic shock. And let me give you the idea that if I consider epidemiological data, more than 70% of 60-70% death is happening because of septic shock, okay, so in the ICU basically. So we have a very important condition here to discuss. So pharmacodynamic क्या changes होते हैं in a sepsis condition? So in sepsis, the body undergoes into a major physiological changes, guys, and that you're blunting further your drugs response. Like receptors may not work promptly, blood flow to tissue is reduced. Inflammation also alters at how the drug reaches to the site of action. And this is why the septic patients often needed a higher or more frequent doses of the drugs. Please remember, septic patient में क्या होता है, they are often needed a higher or more frequent doses. Frequency will be less, it is not as ideal, okay, and dose also higher, okay, in a sepsis patient, right? Drugs like you can say here vasopressure of antibiotics, right? To achieve the same effect you need to go. For example, you can see here vasopressor pharmacodynamics, okay, response blunted due to the receptor down regulation in septic shock, further need a higher norepinephrine doses. Okay, why this is happening? Because of the physiological condition. So you please remember, complex cases में जो होता है, like a sepsis, you need to go a little bit higher. We have some of the more diseases with us in which we require some more modifications, right? For this is the ideal way. Okay, sepsis के लिए please remember, higher or more frequent doses is required. Okay, now let's have one more example. Pharmacodynamics in heart failure. Okay, so we will be seeing a pharmacodynamic profile in the heart failure. So heart failure में क्या होता है? So in heart failure, the body's response, to too many drugs changes very significantly. Body's response to many drugs changes very significantly, like beta receptors become down regulated. Okay, you know what is the role of beta receptor? Okay, see, in this is the decision making class, guys. Okay, so I cannot go everything in detail. I assume that you know some of the basic things like beta receptor, okay, and a heart failure condition and all. Okay, so if you have questions, we can solve it later, do not worry. But for now, just understand that in a heart failure, the body's response to the many drugs changes. And the very first condition by which it is happening, that is the beta receptors, okay, because it is becoming down regulated. So patients initially, responds less to your beta blockers. So heart फेलियर वाले कंडीशन में अगर बीटा ब्लॉकर जा रहा है तो फर्स्ट आपको उसका रिस्पॉन्स इतना नहीं मिलेगा. इनिशियली द रिस्पॉन्स विल बी लेस. Why? Because of the down regulation of the beta receptors. Okay. At the same time, these patients are more sensitive to digoxin. You can say here higher digoxin sensitivity. Okay. Same time पे digoxin के लिए sensitivity higher होगी. Okay, especially when the potassium level of the patient is low. Please remember, when the potassium level is low, and in that condition, you will be seeing a digoxin sensitivity higher and beta receptor down regulated hoga, so that your beta blocker activity will be less at the starting point. Okay, this means even in the normal digoxin doses, that can lead to toxicity, guys. ओके, सो हार्ट फेलियर वाले कंडीशन में आप अगर डीपीरो वाला ड्रग प्रिस्क्राइब करते हो डिगॉक्सिन को, तो वो टॉक्सिसिटी करेगा ही करेगा, राइट? सो दैट नीड्स टू बी अंडरस्टैंड व्हाइल डूइंग अ क्लिनिकल डिसीजन मेकिंग. Okay, please remember these points, very very important. When you are going in a cardiology ward, seeing a patient having a heart failure condition, having a normal digoxin dose, ideal digoxin dose जो नहीं होता है ideally, but when you are observing this, please suggest, okay, this is your role, this is your duty, okay, this is your primary role to do. Our primary role is this, okay, correcting, advising, okay. So we are not here to collect the cases, we are here to justify the reasons, we are here to make changes in the prescription. Okay, we always have that mindset that the people who are having abroad the family, they are always pay, you know, very they are paying the good amount of time, and also they are having a good amount of positions and pay also, right? But this is not like that. Their responsibility and roles are also very tough. Okay, if you are a family fifth year or sixth year student, ask yourself if you are able to do certain changes in the prescription, right? You are not, because we are not having that confidence. Okay, so it start always from us. Okay, so please remember these things. If the patient's condition is like that, low potassium, digoxin का toxicity रहेगा, sensitivity higher रहेगा, and the person who is suffering from heart failure will not initially respond to beta blockers because of beta receptors down regulation. Okay, so in heart failure, we must adjust the doses very, very carefully and monitor electrolytes balance to avoid any kind of adverse effect. प्लीज रिमेंबर. ओके, हार्ट फेलियर वाले कंडीशन में ये चीज का ध्यान रखना है. सेप्सिस हमने समझा. नाउ next condition we need to understand, that is pharmacodynamic profile in the obesity. Now what is happening in obesity? So I hope you are aware of obesity term. Okay, so in obesity, drug response further changes because of increased fat mass. Okay, I can say that increased fat mass, and also I can say that it is altering receptor distribution. Okay, what happens in obesity? Lipophilic जो drug होगा. Okay, I hope you know the meaning of lipophilic drug. Okay, so lipophilic drugs may get stored in a fat. Okay, increase adipose receptor for lipophilic drug means lipophilic drug जो है वो store होता जाएगा in fat because of the nature, leading to delayed and prolonged effects. While on the other hand, we have hydrophilic drugs. Okay, so hydrophilic drugs may become underdosed. Okay, hydrophilic drugs में क्या होगा, वो underdose रहेंगे if the dose isn't adjusted properly in case of obesity. Okay, this is why. So sorry, just a minute. Just give me a minute. I am coming back in a 1 minute. Just a minute. Okay, I will call you later. Okay. Okay. Yes, I hope I am audible enough. So, what is happening in pharmacodynamics in obesity? Obesity may lipophilic drugs that they may get stored in a fat, leading to delayed effect. And on the other hand, we have hydrophilic drugs that may become underdose if the dose isn't adjusted properly. Okay, and this is the exact reason that why obese patients are at higher risk always of getting, subtherapeutic antibiotic doses. Okay, so very very important, obese patients are at higher risk, guys, at a higher risk of getting a subtherapeutic antibiotic doses, which is not as ideally written in the textbook. Okay, such as very important ceftriaxone or piperacillin tazobactam combination. So unless doing it, is individualized based on weight, you need to calculate, and the drug properties you need to check before prescribing these very simple drugs in obese patient. Okay, so that is also a decision making part. Okay, very very important. I hope you are taking it Okay, so we need to discuss a lots of things, but this is a short term course I have introduced, just because I was having a little bit of fear that the population will not accept this heading. Okay, pharmacy people will not accept this heading, advanced clinical pharmacy practice and decision making, and not many I will get. So that is the reason why I have introduced a short course first. So I always do this practice, right? I am introducing a short course, and if the people are interested further to learn it in extensive form, then I will introduce a long term course, right? So that is the reason why I have put a little amount of examples for your understanding. This is a short term, just to introduce you to the terminologies, okay, to the heading. Okay, but I seriously want that everyone should learn decision making. Okay, also we have a complex disease, liver. Okay, so liver disease is here, so we'll understand pharmacodynamic profile in the liver disease, what is happening in liver condition. So in the chronic liver diseases, what happen, I am again repeating, chronic. Okay, so in chronic liver disease, the brain becomes much more sensitive, guys. Okay, brain is becoming much more sensitive to the medicines that is acting on the central nervous system. Okay, why? Because this is directly connected. This happens because the liver cannot properly metabolizing these drugs, and toxins are building up. Okay, which is further affecting the overall CNS, functions. A strange connection, but it is. Okay, this is a very strange connection, but it is. Please understand. Chronic liver condition में क्या होता है? The brain becomes much more sensitive, because this is happening because the liver cannot metabolize properly the drugs, and toxins are building up, and this is affecting the overall brain function. So as a result, even a small dose of drugs like benzodiazepines can trigger further severe sedation, or hepatic encephalopathy. और ये मैंने personally बहुत बार देखा है. I have experience of a person who is suffering from this condition, directly has this kind of hepatic encephalopathy condition. Now understand, this is not because of the actual condition. This is because of drug. This is because of drug induced. This is because of adjusted dose is not proper. Okay, so this is the things which are happening in the hospital setting, right? And we are the one who are responsible for this kind of conditions. Okay, and we can actually stop it if you know, okay, the exact mechanisms. So as a result, what happens, small doses of drugs like benzodiazepines that can trigger severe amount of sedation or hepatic encephalopathy risk is there. And that is the exact reason why dosing must be very conservative, conservatively adjusted in the patient with cirrhosis. So जो भी patient है जो liver cirrhosis से गुजर रहा है, you need to adjust doses if you are going to use certain medicines like benzodiazepines. Okay, so that is another pharmacodynamic profile you need to understand. Now, we have second. Now, the first concept is clear, that in a very complex condition, general conditions I took, right? So, in a complex condition, how pharmacodynamic profile shifts. Okay, that is clear to you. Now, section 2, we will be discussing what is PKPD modeling. Okay, so what is PKPD modeling? Very, very important. Okay, so in PKPD modeling combines, it is combined two of the things, pharmacokinetics, okay, what the body does to the drug, and it will combining pharmacodynamics with it, that is what drug does to the body. So by linking this drug concentrations with their clinical effect, in first we will understand the drug dose, and second we will be understanding the effect of the drug. So by combining these two, this model, PKPD model, help us further to predict how a patient will respond to a particular drug, what dose will be effective for a person, and when the toxicity might occur. Okay, so this is the foundation of precision dosing, guys. Okay, this is the foundation of precision dosing. You must be aware of the term precision therapy, okay, personalized therapy, but this term is quite new, precision dosing. Okay, and this is the foundation, this PKPD model, especially for all of the antibiotics, all of the oncology drugs, and critical care medicine. Okay, so it is a basis of precision doses. It is predicting all of the things for you. PKPD model is a very important term. In our upcoming sessions, we have this in very detail. Okay, very detailed concept में ये हम पढ़ने वाले हैं. So do not worry. For now, just understand what it is. Okay, and why it is important. Okay. Next, we have PKPD indices. So in this, we need to understand that how some, very important antibiotics are having a different kind of PKPD mechanisms. So let me explain you that different antibiotics work, that is best depending on how long or how high their concentration stays relative to the, the organism's minimum effective, the consider, sorry, concentration, right? So MIC के according ही उसका पूरा decision होता है, right? So how your antibiotic will going to work in your body, that is completely depend on how long or how high their concentration will stay, okay, in the body. So here we have first, first thing to understand, which is a time dependent formula, okay. You can say here the greater than MIC mechanism. So it is a time dependent drugs like beta lactam. Beta lactam is an example. Beta lactam. So it is a time dependent drugs like beta lactam need their levels to stay above the MIC for most of the dosing intervals. So in that condition, you need to be very precise. So if you are using a beta lactam, it needs their levels, okay, to stay above the MIC. MIC means minimum, we have minimum, effective concentration we need for the drug to show the effect, okay. Also it is a concentration dependent, okay. The very second term we have, that is a Cmax and MIC ratio, that is a concentration dependent drugs, okay. We have a very popular example here, that is the aminoglycosides. Now aminoglycosides need a high peak concentration, Cmax, concentration at max, okay. So drugs like aminoglycosides needs a high peak concentration. So that is what PKPD model suggesting you, right? So everything is one click available. You just need to understand where to search and how to search. Okay. So this Cmax and MIC you should be aware of. Also, we have area under the curve and MIC ka level of concentration. Okay. So it is again giving you the exposure dependent drugs. For example, we have vancomycin and fluoroquinolones. Now, this kind of drugs, that needs the right total exposure over 24 hours. So in which we need a AUC curve. Okay, I will be explaining these indices in detail in our upcoming sessions. So if you are not taking it right now, it is completely normal. I will be explaining to you that what exactly the meaning of each of the term. Okay, but for now, shortly, because today we have to discuss broad parameters because it is a module number 2, right? So we cannot dive into a one particular topic. First, your picture should be clear, broad area should be clear, and then we will dive deep into each of the topics. Okay, so please understand this vancomycin and fluoroquinolones that needs the right total exposure over the 24 hours. So understanding this, the formulas you can say, or the concentration related things further help you to choose the right dose for the right patient with right dosing schedule or intervals for each of the drug. If you know that vancomycin fluoroquinolones must be over the 24 hours, you need to check aminoglycosides at a high peak concentration it requires, okay. Beta lactam also needs their levels to stay above the MIC, okay. So that you need to be aware of. I am giving you ample amount of examples later, but for now just understand these are the things that needs to be at your at with you to understand and to make a clinical decision in the practice, okay. Also, we have here the example of meropenem that must say, that must stay above the MIC for 40-50% of dosing interval. So it is a prolonged infusion, okay, that is improving success of meropenem. Meropenem is again a very, very important drug. This example I will be taking in our next session briefly. Okay, so do not worry. Meropenem को हम बहुत ही अच्छे से सीखने वाले. This is one of my favorite drug to discuss all the time. So that is the reason why I have included the example here. So please understand that these are the things which needs to be corrected if you are aiming for the decision making, right? Okay, next you need to understand is PKPD in oncology, which is very important to understand. So what happens in the cancer? In oncology, dosing is designed to, maximize tumor kill while limiting the toxicity. Why? Because anti-cancer drug का toxicity profile भी बहुत ही ज़्यादा huge होता है. We have a huge profile of toxicity of anti-cancer agents. So particularly it is design, अगर आप बात करें PKPD मॉडल का, तो इस तरह से डिजाइन किया जाता है कि मैक्सिमम ट्यूमर किल एक्टिविटी मिले while minimizing the toxicity on the second head. So PKPD model help us to predict how this chemotherapy drugs, will going to behave in the body and how much exposure is needed for the effectiveness. कितना exposure देना चाहिए, right? So a good example we can take here is I can give you the example of carboplatin. Carboplatin is a chemotherapy drug, okay, which is dosed, which is dosed using the Calvert formula. There is one formula known as CALVERT, Calvert. तो उस ये जो फॉर्मूला है, प्लीज अंडरस्टैंड, एंड इफ यू आर नॉट, if it is new to you, this is also your homework to understand what is the formula and how these anti-cancer agents are, calculating their doses based on this formula. We have Calvert formula, and based on the targeted area under the curve AUC mechanism, the agents used in oncology, the dose calculation will happen. Okay, very important thing, Calvert formula. And if you know the drug carboplatin, it is, the dose calculation of carboplatin is completely dependent on Calvert formula. So this further, ensures that the each patient, especially those with the kidney impairment, receives a personalized dose that is effective but not harmful. Okay, so tumor growth models predicts this optimal cytotoxic behavior of the drug. Okay, and it is maximizing tumor kill and minimizing toxicity further. So oncology profile is a very important thing to understand when we are talking about PKPD. Okay. Okay, this is the example here. Carboplatin dosing via Calvert formula. Okay, based on area under the curve, it is being identified and it is being calculated. Okay, so you need to be aware of when you are dealing with the oncology things. Okay, next we have PKPD in the critical care condition. So in the critical ill patients, normal pharmacokinetic doesn't even apply. Okay, so let me be very clear to you, it is not apply. Their fluid is shifting, inflammation is there, organ dysfunction is there. Okay, and aggressive, form of the condition you will see in the critical care. Okay, and all change, how the drug distributed and how it will clear from the body, all affects all together. Okay, so many ICU patients have increased volume of distribution. Okay, volume of distribution will be very, very high, and sometimes you will be also seeing augmented renal clearance, which is also known as ARC. Okay, augmented renal clearance, meaning they cleared drugs faster than expected. Augmented renal clearance means they will flush out. Okay, all your drug dose will be flushed out fastly because of the changes in the body, right? Because of the disease condition, of course. So augmented real clearance you will also observe. So because of this, they often need, higher or more frequent doses. Okay, in our previous one of the condition also, we already understood that in that condition we need a higher or a frequent doses, especially for antibiotics, to achieve the overall therapeutic concentration. Okay, because increase volume of distribution बहुत ज्यादा होता है, augmented renal clearance होता है, and SIRS induced PK variability is also the challenge. Okay, so let me be very clear to you. This is very important when you are seeing a critical care patient in the ICU, where major chances that you can be the reason behind saving drug induced toxicity, because ये बहुत mistake होता है, बहुत ज्यादा experience किया है ये. Okay, so SIRS, again, I would like to remind you that SIRS is a systemic inflammatory response syndrome. Systemic inflammatory response syndrome. If you are noting it down, please note it down. Inflammation के कारण बहुत सारे symptoms एक साथ आ जाते हैं, which is a meaning behind the syndrome. Syndrome is a combination of symptoms, right? So that induced PK variability is also the challenge, and for that reason we required higher or more frequent doses in the critical care. Okay, and you can have the example here also. Young trauma ICU patients, very high creatinine clearance, requires higher beta lactam doses. Okay, critical care is one of the biggest area where you can perform. Okay, you can make an impact. Okay, next you need to understand is a PKPD case example of antibiotic dosing. So this is a case example for you. See here, a patient is having 65 years of age, male patient, and having a severe pneumonia, high MIC pathogen. Okay, so here is a practical example of PKPD action. So again, I am repeating, 65-year-old patient with severe pneumonia and has a pathogen with high MIC, meaning the bacteria needs a higher antibiotic concentration to be killed. Okay, high MIC लिखा हुआ आता है, that meaning this bacteria needs a higher antibiotic concentration to be killed. Okay, so here a standard piperacillin tazobactam dosing may not stay above the MIC long enough. यहाँ पे ज्यादा देर तक नहीं कर पाएंगे hold, right? So instead of we use extended infusion, which keeps the drug concentration, above the MIC for a longer period, improving overall clinical success, and we can also reduce treatment failure here. So what we will go for, extended infusion of the particular antibiotic. Okay, standard जो dose है हमारा piperacillin tazobactam will underperform in this situation. Why? Because of high MIC. This pathogen needs more concentration to be killed, right? So standard dose will not act. Solution is extended infusion for longer. The very first formula what we learned, greater than MIC condition. Okay, so where you need a dose which is greater than MIC, which is further improving clinical outcome. But let me tell you, it comes with a side effect. Okay, we need to modify, we need to monitor also. Continuous monitoring is required in this situation. Okay, but understand that in case of age related condition where the comorbid conditions are also there, and you are treatment failure बहुत बार देखा है, then you can switch the therapy to this kind of extended infusion. Very, very important case to understand. Next, we need to understand PKPD modeling tools. What do you mean by tools? So PKPD tools, these are the tools which we are having. You can see on the slide. These tools further help us to make dosing more accurate and personalized. If you are not using right now, do it from tomorrow. Okay, search it, how to use it. You have also YouTube with you. One click available. All the software details are with you. I am here to direct you that you can go for this. Okay, so these are the tools that is very useful to us. Okay, we have very first, that is Bayesian dosing software, right? And this software is like Dose May RX. You can see a DoseMeRx is the one of the software. We have Insight RX also. We have Precise PK also. These are the software, guys. Okay, and these are very important. Patient specific data ये जो है दिखाता है, like age, weight, labs, and drug level you need to enter to calculate the ideal dose. So all the things like age, weight, labs, and lab detail and drug level you need to first enter, and it will calculate the ideal dose. Again, it cannot solve your 100% query. You cannot be 100% rely on the software. This is software, guys. It is giving you the idea about whatever stored data it has. Okay, your knowledge is ultimate. Okay, but you can have help. You can have help, right? A micromedex you are using on a daily basis, right? So for the same thing, dose calculation ke liye, these are some of the software which are very, very important. Also, we have mathematical compartment model. For mathematical compartment model, we have, such as one or two compartment models we have. This is further helping us to predict how drugs behave in different patients. Okay, so that is also we have. And these tools are very, very specially useful for the drugs with the narrow therapeutic index, that I can say, जिसका therapeutic index very narrow होता है. For example, warfarin. Okay, जिसमें आपको बहुत precisely dose calculate करना पड़ता है, otherwise a little bit of high amount will lead to the condition like hematuria, right? The blood will come into the urine. So जिसका therapeutic window बहुत ही narrow होता है, those kind of drugs needs dose calculation, and for that you can use certain tools like this ultimate. Okay, and for example, vancomycin also we can take, aminoglycosides also we can take, warfarin also we can take, right? So for those agents you can always prefer this kind of modeling tools. Please remember, DoseMeRx, Insight RX, Precise PK, this all we have. Okay, I will also show you in our upcoming session how to use it. Do not worry, I have a video also to demonstrate. I have some of the activities also to perform. Okay, but this is the base, so I need to be more theoretical. Okay. Next, we need to understand is a dose optimization. What do you mean by dose optimization? You should be very clear. So, dose optimization means tailoring the whole drug dose to the individual patient rather than using one size fits all approach. Okay, एक ही size सबको fit हो जाएगा वो approach पे नहीं जा रहे. We are doing a individualized dose planning. So that is a dose optimization. So we are looking at factors like age. Okay, we are looking at organ function. We are looking at weight. Okay, weight we are calculating based on this data. Okay, we are also going with the some of the pharmacogenomic profile, disease severity. Okay, and we are going to see such all the things together. The goal is very clear. The goal is to give a dose that is more effective enough to treat the condition while avoiding a toxicity. Okay, and this is the core. This is the core dose optimization. It is in the, we can consider a core of personalized pharmacotherapy. Okay, so this is considered as a core of personalized pharmacotherapy. Very, very important. For now, just understand what is the meaning of dose optimization. In our upcoming session, we will understand how to do it. Okay, ये कैसे करेंगे ये भी मैं आपको बताऊंगी, but in our upcoming session. For now, remember the definition of dose optimization. When I say do a dose optimization means you need to calculate, you need to understand whole background of the person, and then you are calculating the dose for the patient, which is a personalized, individualized. Then you are doing a dose optimization. Okay. Nowadays, this term is misused. भी बहुत होता है. People are doing traditional practices. Clinicians are also doing traditional practices of prescribing, and they are calling it a dose optimization, but it is not. If you want to do it, it takes time, and it requires a lot of data also, which can be sometime impossible to collect. Okay, some of the practical challenges are also there, but I will tell you how to do is, okay, dose optimization बहुत ही अच्छी तरीके से किया जा सकता है if you want. So I will share all the details in our upcoming sessions. Okay, for now just understand these are the tools, guys. These are the tools, advanced pharmacotherapy we need to understand for decision making. Very important word, TDM. You have a whole subject in the fifth year, right? Therapeutic drug monitoring. बहुत ही important word हो जाता है ये. So we need to understand that TDM is used. Therapeutic drug monitoring. The name itself, it is in the title. Okay, we need to monitor the drug therapeutically. Reversely, you can remember. Okay, so TDM is used for the drugs that have again very narrow therapeutic range और high variability between the patient. Okay, जो ड्रग ऐसा है जो हर एक पेशेंट में अलग अलग तरीके से एक्ट करता है, दैट्स की एफिकेसी हर एक पेशेंट में अलग अलग मिलती है, और जिसका थेराप्यूटिक विंडो और थेराप्यूटिक रेंज बहुत ही ज्यादा नैरो है, उसमें ही टीडीएम किया जाता है, राइट? टीडीएम इज बीइंग परफॉर्म्ड इन दोस particularly those drugs. Okay, you can see here drugs requiring close monitoring are listed here. Okay, so by measuring the drug level in the blood, ये कैसे करते हैं TDM? We are measuring drug level in the blood, like we'll see the vancomycin, aminoglycoside, tacrolimus, digoxin, phenytoin, and then we can adjust the doses more accurately. Okay, so it helps us to ensure that the drug stays in the therapeutic zone. जो है उसका मिनिमम इफेक्टिव कंसेंट्रेशन हमें चाहिए वो वहां तक बना रहे. ओके, इट विल प्रोवाइड अस द रेंज ऑल्सो. And also therapeutic zone means high enough to work but low enough to avoid toxicity. Okay, high enough to work and low enough to avoid toxicity. Okay, so that is TDM. We need to be aware of this term in order to get the better clinical decision making skill. Okay, so samples taken at steady state or through some of the, you can see here the picture, some of the laboratory tests. So I will show you how to do TDM also. We will be having a descriptive theory on it. So yes, this concept is also helping you for the decision making. Just give me a minute, guys. I have a lecture at 7:30. I'm just messaging them that it will be 5-10 minutes. We'll have a later. So just give me a minute. Okay, so get back. Okay, so TDM is again very important term to understand. Okay, I hope it is clear. Now, we are seeing the vancomycin AUC guided dosing today to understand it little bit more, in detail. So, see here, all the details I will show you and then I will explaining to you. So, this is very important thing, vancomycin AUD guided dosing. Okay, vancomycin dosing has shifted from, through the level monitoring to AUC guided dosing because it is shifted actually because this AUC and MIC का जो ratio होता है that gives a more accurate picture of the drug exposure, guys. Now, what is happening with vancomycin? The recommended target is, and the AUC MIC curve of 400 to 600. The new standard is this, which provides very, very effective, bacterial killing while reducing the kidney toxicity also, which are associated with vancomycin. But studies shows that this AUC based dosing leads to less nephrotoxicity compared to traditional method what we are having. So this is making it a very better and safer and precise approach. So this is shifting. This vancomycin approach is being shifted. Okay, because vancomycin is having a very big profile for nephrotoxicity. So lower nephrotoxicity versus it is through based dosing. Like we can see that the doses are being reduced and the new profile of vancomycin is come up with the less nephrotoxicity and better outcome. Okay, so switching to this AUC based dosing, this is for the reducing AKI, like acute kidney injury profile in the hospitalized patient, that is who is receiving a vancomycin. So this is what happening worldwide. Okay, this is what emerging currently. सो ये कैसे हो रहा है, ये सब हो रहा है बिकॉज ऑफ द क्लिनिकल डिसीजंस. ओके, एंड दे आर टेकिंग डिसीजंस, दे आर neglecting the traditional practices, they are updating all the things, which is very very important thing to understand. Okay, vancomycin का example हम हर बार लेंगे because this is a very important drug to understand. Next, we have dose optimization in renal failure. Okay, so कैसे करेंगे in renal failure dose optimization? So in renal failure, the kidneys cannot clear drug effectively, right? So drug level can build up again and can cause toxicity. So that is the reason why many medications, especially renally cleared one, like piperacillin tazobactam is the one which is almost like 99% clear out from the renal route, right? Or again, some of the low molecular weight, like heparin also, that is need dose reduction or extended dosing interval if the patient is suffering from renal failure and taking piperacillin tazobactam or heparin. Okay, in that condition what is needed, जो intervals है dose के बीच का वो बढ़ाना पड़ेगा. We need to extend the intervals. Okay, because kidney is taking too much time to clear it out. Okay, so proper adjustment based on the creatinine clearance or patient's EGFR help us further to maintain the therapeutic effect while preventing the harmful accumulation. Because अगर accumulate हो गया, toxicity is on a huge level. Okay, so you need to be aware of dose optimization in the renal failure. Okay, and low molecular weight heparin like enoxaparin, heparin, those are at also higher risk of bleeding. Okay, in the CKD patient, very very important, high risk of bleeding in chronic kidney disease. So dose optimization is must in the renal failure. I think this might be this is not new to you. You might be aware of these things. Okay, CKD एक proper common condition है. एंड जो दवाइयां जो होती है जो नेफ्रोटॉक्सिक होती है उसके लिए डोज ऑप्टिमाइजेशन करना पड़ता है, राइट? आई विल शो यू हाउ टू डू इट, डोंट वरी. Dose optimization in hepatic also we need to understand. So what happens in hepatic impairment? The liver's ability to metabolize drug is reduced. And this means drugs that rely heavily on the liver metabolism that can accumulate and cause toxicity further. Okay, so यहाँ पे क्या करेंगे, हमारे पास एक टूल होता है that is child pug scoring. Okay, using tools like child pug scoring, we adjust the doses or we choose further the safer alternatives. For example, high doses of paracetamol or strong opioids that should be avoided, and the doses must be started at a very low concentration and titrated also. Like doses can be titrated also carefully in the patient with suffering from any kind of liver cirrhosis or hepatic impairments. You can see here, start slow. Okay, start low also. Dose low dose opioids you can start, and this scoring help us to understand how to optimize dose in the hepatic impairment. You must remember the names. Okay, you must remember the names. Otherwise, the things are pretty simple to understand. Okay, in hepatic conditions. Next, we have weight-based dosing. So weight play a major role, as I earlier discussed the obesity with you. Weight play a major role in how the drugs distributed in the body. Some drugs need to be dosed using a total body weight, that is a TBW, total body weight. Especially lipophilic drug जो होता है, that can accumulate in the fat. So lipophilic कैटेगरी वाली जो ड्रग होती है उसके लिए हमें टोटल बॉडी वेट चेक करना पड़ता है, राइट? Other drugs needed ideal body weight, that is IBW, ideal body weight, or adjusted body weight, adjusted total body weight, that is adjusted TBW. Particularly hydrophilic drugs like aminoglycosides, which don't distributed much into the fat. So using the wrong weight can lead to underdosing or toxicity profile. So choosing the correct weight, जो आप metrics choose करोगे correct weight का, that is very essential for accurate dosing. Okay, so I am also mentioning here that lipophilic drug, like for example midazolam, that dose is calculated based on TBW, total body weight, while hydrophilic you need to go for adjusted type of the total body weight calculation. How to do it, we'll see in our practical sessions. So you will be more aware of how exact. This is also part of dose optimization, guys. Okay, I'm just making you aware that these kind of things are there, formulas are there. So it might not be new to you in our upcoming sessions where we will dive deep. Okay. Okay, very good. Now we have a pharmacogenomic consideration. So at the starting time pe hi discuss kiya ye, right? So genetic differences can also affect how patient metabolize or react to certain drugs. For example, we have a huge family with us, CYP450 family. For example, CYP2C19 that is responsible for variation changes how the patient respond to proton pump inhibitors, or I will also say clopidogrel. Okay, if you remember. क्लोपिडोग्रेल भी CYP2C19 से ही मेटाबोलाइज होता है, right? So if the patient is having CYP2C19 ultra rapid metabolizer or poor metabolizer category, the drug will need changes accordingly. Okay, CYP2C6, 2D6 we have for opioids. Okay, that is affecting the activation of many opioids. Some genetic markers also we have, for example, HLA-B1502 that can predict that severe reactions such as carbamazepine induced, some of the SJN and TEN condition. Okay, I will not go in detail about it, but understand that HLA-B1502 variant अगर present है तो carbamazepine lead hypersensitivity हो सकती है, that can predict adverse drug reaction for you, genetic profile. So by knowing a patient's genetic profile, we can individualize drug therapy to improve its effectiveness and avoid further the severe adverse drug reactions also. But it is not quite easy. Okay, we need a genetic test for it, and which is very costly and very hard to convince patients for genetic testing as well. So we have here the example like CYP2C19 poor metabolizer अगर होगा तो omeprazole का जो effect है that will be little high, because it will not metabolizing it as speedily as required. So dose reduction is required in case of TYP2C19 poor metabolizer. अदरवाइज बिल्डअप होगा, राइट? सो ये बिल्ड ना हो, डोज इंटरवल बढ़ाना पड़ेगा या फिर रिडक्शन करना पड़ेगा. ओमेप्राजोल की जो इफेक्ट है वो ह्यूज लेवल पे मिलेगी बिकॉज इट इज नॉट मेटाबोलाइजिंग इट एज स्पीडीली एज इट शुड बी. Okay, so that is the pharmacogenetic consideration. We have here the case example of precision dosing, which is a tacrolimus, very important drug. So see here, tacrolimus is a drug with the very high variability, guys, right? When it comes to pharmacokinetic profile of the drug. So it is having very high variability between patients, especially those who have received organ transplants, right? So small changes in the dose that can lead to either rejection of the transplanted organ or a serious toxicity. And that's why the therapeutic drug monitoring, TDM, is essential for tacrolimus. Okay, and doses are also adjusted further frequently based on the this tacrolimus level. So genetic factor like CYP 3A5 that is also influence how fast a patient will metabolize tacrolimus, further helping us to predict whether they will need higher or the lower dose. Very important if you are going to use a tacrolimus, right? So this makes tacrolimus a perfect example of precision and individualized dosing. Okay, because it has higher variability, because it is used in transplant patient, TDM is very important in this particular condition. Genetic is also involved. Best example to understand precision dosing. Okay, so very, very important to understand. Now, managing adverse drug reactions and ADR. So you might be aware of the types of ADR, guys, right? Adverse drug reactions are classified further into different types to help us to understand their causes and prevention. So type A is predictable, dose dependent. Type B is idiosyncratic, okay, unpredictable or allergic reactions, we can say, like penicillin hypersensitivity, okay, unpredictable. Type C, we have chronic reactions. Type D is for D to D delayed, okay. E is withdrawal, and F is treatment failure, often due to drug interaction or, underdosing. Type F. So knowing this type of how many types of ADRs we are having, this is further helping us to identify, to manage, to prevent ADR more effectively, right? Very, very important it is. Okay, predictable, idiosyncratic, chronic, delayed withdrawal, and treatment failure. Now, ADR risk factor I will show you. Types is very easy to understand, but what are the risk factors of ADR? So yes, certain patients are more likely to experience adverse drug reactions. Like older adults and children are at high risk because of their bodies handles drug differently, right? Polypharmacy increase the risk. Okay, renal or hepatic impairment reduces the drug clearance, leading to the toxicity. Pharmacogenomics differences and interacting medications can further increase ADR risk. Right? Identifying these risk factors, अगर आपको एक बार पता है, that will again help you to adjust the therapy and prevent the harm also. Okay, so ADR के लिए बहुत important है to know the types, to know the risk factors associated with ADR. Preventing ADRs, how to do it? So to prevent ADRs, we need to be a proactive approach. यहाँ पे हमें चाहिए एक proactive approach, right? Medication reconciliation helps us to ensure patient is on right drugs without duplication or dangerous combination. What do you mean by medication reconciliation? So let me tell you, अगर एक patient आपके पास आता है, so you are assessing the whole prescription, whether the patient is receiving any kind of, prescription drug, OTC, herbal products, anything, you are considering it, you are checking it, and then you are advising. That is a medication reconciliation process. Okay, reviewing all together. Stop and start criteria we have. Okay, so tools like stop and start criteria again guide us for the safe prescribing, in the older adults. Older adult के लिए बहुत अच्छा formula है. Stop and start criteria hai, right? Regular monitoring for labs and symptoms again help us to detect the problems early. Avoiding high risk combinations like AC inhibitors with spironolactone. Let me tell you the clear example. See here, AC inhibitor with spironolactone, right? So these are the predictable kind of combination that you should avoid, right? Because it can also reduces some of the preventable ADRs, I can say, right? So overall, we can say prevention depends on careful review, careful monitoring, and individualized decision making. Okay, very, very important, preventing ADRs. Clinical monitoring for ADRs. So monitoring is essential to catch ADR, guys. Very, very important word here is a monitoring, right? So we use laboratory tests like liver function test, kidney function test, blood counts to detect the organ toxicity. And we also look for some clinical signs such as rashes, confusion, bleeding, or some gastrointestinal symptoms. So we have tools. We have tools with us. We have Naranjo scale to monitor it. This scale further help us to determine whether a drug is truly responsible for a reaction or not. And effective monitoring further ensures timely intervention and the safer patient care. You need to be very, very aware of this Naranjo scale. Okay. In further sessions, I will be explaining to you what it is, how to use it. Okay. For now, just make yourself aware of the term. Okay. Okay, we have here the short example to study, which is the ADR analysis. So in this case, a 70-year-old woman, you can see here, taking warfarin was also prescribed a combination which is TMP-SMX for infection. Okay, so this combination can dangerously increase warfarin level because this TMP-SMX that inhibit CYP2C9, okay, the enzyme which is responsible to metabolize warfarin. तो अभी ये दोनों के कॉम्बिनेशन में क्या हो जाएगा, वॉरफरिन का जो लेवल है वो बढ़ जाएगा. ओके, हर INR rose further to 5.5, you can see, putting her at high risk of bleeding, internal bleeding, right? So the correct management is to hold warfarin first. Here एक करेक्ट मैकेनिज्म क्या होगा? टू होल्ड वॉर्फरिन, टू मॉनिटर INR very closely, and counsel the patient about the drug interaction. Okay, but this case shows us how important it is to check the interaction before prescribing. Okay, so very important word. And ये मैंने खुद एक बार देखा था ICU में, that the patient is having warfarin plus TMF, TMP, SMX combination, INR further raised to very high level. Okay, immediately दिखता है ये, very important. Next, you need to understand what is the importance of documentation and reporting. Okay, so proper documentation and reporting of ADR are the very essential part for the patient safety and improving overall healthcare system, right? You are aware of this thing, I think. So when we record an ADR clearly in the patient's chart, it helps us to prevent the same mistake from happening again. That is what the fundamental thing, right? So reporting some of the very serious or unusual ADR to the national programs like PVPI India, that contribute further to pharmacovigilance, right? And it is further helping us to identify the safety issues at the very population level. So clinical pharmacists play a major role here in monitoring, documenting, and promoting a culture for safe medication use. Vigilance जो है post marketing surveillance का part है. I will be discussing pharmacovigilance in detail with you in our upcoming sessions. End वाले जो sessions में उसमें ये include किया गया है. So it will give you the idea about vigilance things. Okay. What is the summary and the key takeaways we are having? So complex disease alters PD significantly. PKPD modeling is essential for precision therapy. Okay. Dose optimization must be individualized. Active ADR prevention improves outcome. And clinical pharmacists play a central role in advanced pharmacotherapy decision making. How now it is clear to you, right? So I hope it is the session is clear to you, and it is a very important things to understand. See, we were discussing today very basic things, right? And we need to be very precisely aware of this terminologies to again jump into some some of the very detailed condition. So in our upcoming session we have case scenarios, so I will be discussing it with you. So guys, if you have any questions, please see, I'm feeling that I was little bit speedy today because I have second session, but don't worry. If you have any questions, also I think you might be suffering from the issue with the timing also. 6:30 is not uh, good time for you. So I'm thinking from the next Thursday, we will be having a lecture after the dinner time also, if you guys are comfortable with it. If 6:30 is not good, okay. I will ask in the group, share your suggestions with me related to time. We will solve these things and we will come up with the time which is convenient, in which, yes, recording will be available today. Today, I will share the recording. I will tell you my team that you guys are needed. Okay. Uh, yes, I will share. Okay. Okay, see, all of your questions, I'm taking the screenshot here because I have another session in line and there is a slight, in timing interaction is happening. Uh, but I will solve this issue by the next Saturday, I promise. Okay, I want to answer these questions, guys, but I'm taking a screenshot and I will answering in all this, questions to in a WhatsApp group today before I sleep. Okay, so do not worry. And also in group also you can ask your questions as many as possible. Okay, we will discuss for sure after 1 hour. Okay, thank you so much for your understanding. And yes, attendance, I will it is already a recorded session, so attendance is taken. Thank you guys for joining. I'm in a little bit hurry. I'm so sorry, but by next Thursday I will solve this issue. Okay, uh, forgive me. Thank you so much, guys, for joining. Thank you so much for cooperation and understanding. Thank you.